you are continuing to stay safe and healthy in these challenging times. We're delighted to have members of the University of Chicago community join us this evening for a very topical webinar that is being co-hosted by the University of Chicago Center in Delhi and the International Innovation Corps. The topic is the evolution of pandemics, and we will hear from Anup Malani, the Lee and Brena Freeman Professor at the University of Chicago Law School and Professor at the Pritzker School of Medicine. Anup has conducted extensive research, not only in India's slums, economics, but the healthcare system over the last few years. And his work has got funded by a range of organizations, including USAID, the Gates Foundation, Tata Trust, and Michael and Susan Dell Foundation. Many of you joining this evening know him as a co-founder and the faculty director for the International Innovation Corps, which is a very successful social impact fellowship program that runs as a part of the University of Chicago Trust and the Harris School of Public Policy based at the center in Delhi. The program brings young professionals to government and not-for-profit organizations for a period of 1 to 2 years. Today, however, Anup will focus his research and speak on the work that he's doing, which is very pertinent to today's challenging times about the pandemic, his understanding of how the response to the pandemic has evolved, and how societies are responding to it, both in terms of public health and the overall economy. Anup has set up a working group which comprises of academics from a number of universities, MIT, Stanford, Duke, among those. And this came together when the pandemic struck to develop models and do empirical work to support the response to COVID in India. Anup and his colleagues were also acknowledged for their work through the Emergent Ventures Prize that they won in June this year. He's a very reputable voice in the academic and policy circles, both in India and in the US. Anup, congratulations again on the well-deserved recognition on the topical work that you and colleagues are engaged in. And thank you for taking the time to speak today to such a close group of the UChicago community members. I will just end before I give the stream to Anup to say if any of you have any questions, please do put them up on the chat box and we will try and have as Anup answer as many of them as possible. Thank you, and Anup, over the sharing the screen with you now.
So Aditi, first, thank you very much for the opportunity to present the work that we're doing. I also want to thank the university and the Delhi Center for the support that they gave in Delhi and in India to be able to conduct our work. Obviously, it's very difficult to do this remotely, but having a local platform has made a big difference, both in terms of the policy advice and our ability to do the research. So we're extremely grateful for that, and we thank you. I also want to thank Shreya, who heads up the International Innovation in India. She has done a spectacular job in pivoting from the existing work that we're doing to support the Ministry of Health in their pandemic response. And I would be very happy to actually just turn this over to her and have her and her team talk about the ways in which the IIC has helped the Ministry of Health, Niti Aayog, and others in the center to address pandemic response. I think you'll see a lot more of the work that the IIC is going to do on COVID and COVID-related relief in the months to come. But here, let me focus a little bit on the work that we've been doing aside from the IIC. So if you permit me, I'm going to go ahead and share my screen and give a short presentation. I assume everybody can see my screen, so if somebody could just give me a thumbs up to make sure. Anybody?
Yes, Anup, you are visible.
Okay, great. Okay, so the title of this presentation, I think, was set to be a little bit grander than what I'm gonna than the content. But let me tell you that I will focus first on my research prior to the epidemic, and then focus on the research during the COVID epidemic. So first, by way of background, as it turns out, fortuitously, a significant amount of my research prior to the epidemic was actually on epidemics, in particular the interaction, the role that economics can play to help understand behavior and outcomes during the epidemic. Some time ago, nearly 15 years ago, I began my career doing work on antibiotic resistance. So this is bacteria becoming resistant to antibiotics. And we focused on how you can incentivize providers and other healthcare participants to limit their use of antibiotics so that they don't cause a negative externality in others, which is that their use causes other people not to be able to use antibiotics because bacteria become resistant. And so we talked about how you get people to internalize that risk. And then separately, over the course of a series of papers that continue to today, we've looked at the incentives that countries have to report disease, often infectious disease. And the main punchline here is that reporting is going to be a function of what the consequences of reporting are. So in the context of COVID, the issue is governments that want to not have a lockdown, for example, might suppress reporting of cases or deaths. And you can have the opposite. If there's going to be some assistant that comes with it, you might have people exaggerate the risk. For example, if a government is committed to lockdown and wants to convince the population that it's necessary, they may actually sample the more severe cases. And we've seen examples of both around the world. In the past, I've also looked at how you incentivize people to actually comply with infection control methods. And so I have this paper with Maciek Boni and others talking about how you get chicken farmers to comply with controls during the avian flu outbreaks that we saw repeatedly starting in 1997 in East Asia. I've also talked about how one of the big issues that comes up in the COVID epidemic is whether or not people are compliant with things like masks, whether they socially distance more generally. Well, whether or not they do those things strongly affect the epidemic, but whether they do them depends on how serious they think the disease risk is. And so we explored in a paper about 5 years ago how it is that people form beliefs about the infection during the epidemic. And our application was actually SARS in Taiwan. And we showed that there was a lot of herding, a lot of group mentality when it came to forming these beliefs. And in some cases, in many cases, it can lead to kind of not unbiased, but irrational beliefs. And I can unpack that if somebody wants to talk about it, but basically herd mentality. In the case of SARS, it actually, in Taiwan, actually helped hasten the decline of the disease, but it can go the other way too. If people think that there's not a bigger risk, you can actually exacerbate the situation. And then more recently, I've been working with epidemiologists again, trying to understand how infections evolve. And in this context, we're looking at seasonal flu and how seasonal flu evolves, and in particular, how vaccination affects the evolution of flu. Our prior going in was that vaccination, like antibiotic use, would accelerate the evolution of the flu. And in fact, surprisingly, our simulations suggest the opposite happens. And that helps explain some of the kind of interesting puzzles that we've seen over the years. The most notable being that the US and European strains of the flu, seasonal flu, seem to be displaced year after year by the East Asian variant of the flu. It is possible that, for example, differential vaccination rates can explain that. This can also lead to suggestions for different policies for vaccination, in particular, the importance of vaccinating around the world and not in particular places. But that's a recent paper with Sarah Kobe and Frank Wang. So this was the prior research that we had done going into the COVID crisis. In COVID, we've basically, I've been working on in 5 different tracks, I would say, to help in efforts against COVID. The first, obviously, I stressed earlier, which is the International Innovation Corps. In fact, the credit goes to the IIC teams that are there, in particular those that were working at the Ministry of Health and that were repurposed and went into work every day despite the lockdown and requirements that everybody else stay at home. So they basically became essential workers. So that's very important. I think that's worth a seminar in and of itself. So I'll focus on the remaining portion. The second thing that we focused on, second thing that we did was based upon the IIC's early experience, we realized it was essential for the government to obtain support from the private sector. And so I worked with Ruben Abraham at the IDFC Institute to organize a task force of top leaders, which I'll talk about in a slide. And then we also organized, as Aditi said, a task force of academics from around the world, but particularly US and India, to work on modeling COVID and analyzing data about COVID. So I'll talk a little bit about that. In addition, I've been involved in some other organizations that have tried to take efforts on COVID. So one is the World Economic Forum South Asia Action Group on COVID, which includes a number of prominent government leaders and CEOs, basically to understand how to recover from the COVID crisis. And then more recently, the Asian Development Bank asked me to join a high-level advisory panel to address COVID response and recovery in Southeast Asia. And that has led to some work that's starting now on Indonesia and some other states, and some other governments. So let me focus on those two task forces. Those were items 2 and 3 in the previous list. So as I said, the IDFC task force, IDFC's institute is based in Mumbai, but everything's virtual these days. So this is very easy to organize in some sense. So we organized a task force that had top leaders in business, medicine, healthcare, international organizations, and finance, basically, again, to provide non-governmental, broadly construed support for the government's response. And the focus really was on practical questions. So one of the key things that we did is, and this was formed in the week before the first lockdown on March 24th. So the first thing we did was, when the lockdown went into place, a number of essential services had been cut. And so we worked with, we had a number of logistics companies, including organizations such as Amazon, that would go and call, would organize the trucks that would be coming in, but then correspond with the local police departments to make sure that food supplies could come through. So that was a critical thing. We developed an e-pass system that was subsequently used and adopted by a number of state governments. We had a number of healthcare professionals on, such as Lance Pinto, who helped develop medical protocols, propagate medical protocols, especially based upon recent research, which has been quite helpful. We did a number of efforts to try to promote testing, some of which I'm going to talk about, as that's one of the areas that I focused on the task force. We also did really practical things like, in slums, there was a shortage of water because utilities were cut off too. And the question was, when you have a shortage of water, how do you get people to wash their hands? We also needed to spread information in slums where there was really a lot of worry early on that the epidemic would spread very quickly. Turned out to be a true belief, but talking about how we could encourage social distancing where feasible in slums, tell people about the epidemic to discourage panic. And in addition to those practical things, we also had information seminars where we'd bring in people to come speak, whether it was about what to do during the epidemic or post-recovery reforms. So how do we get the economy back on track? And so those are some of the activities that I was also engaged in. Then on the COVID task force, which is a separate task force, but related in the sense that there was a lot of dialogue back and forth. The COVID task force, as I said, was an academic task force that I put together with folks such as John Gruber and Manoj Mohanan. John is from MIT, Manoj is from Duke. But we had people from Stanford like Ashish Goyal, Brahmar Mukherjee from University of Michigan, Sam Asher from Hopkins, people from Dartmouth, et cetera, a number of universities that had come together to kind of tackle COVID. And what was very interesting about this was it was a interdisciplinary effort that included epidemiologists such as Brahmar, it included economists such as John, it included computer scientists such as Ashish Goyal, physicists such as David Kaiser. I mean, these are very top minds that basically dropped everything else they were doing to be able to assist with response in India. And one of the things that made this possible was that we had the task force. And so we knew a lot of the recommendations that we were going to make were not purely academic, that they would be taken seriously, both by governments, because the connections that the IDFC task force had, and also by corporations, because there were a number of CEOs, a large number of CEOs on the IDFC task force. Now, the task force, the COVID task force, actually focused on practical questions as well, but again, where academic or a deeper analysis was required. And our output was mainly memos to the different governments. So we had 4 or 5 different state governments and the center government talking to us. And so we would often take their questions, write a memo in response. In cases where we had to speak to a number of different governments, we would write op-eds that were targeted at those governments and a common question that they had. So let me focus a little bit on testing and get into substance a bit, if that's okay. So a lot of the work we did was actually just writing short reports. The time was of the essence, so we didn't convert them at first to academic papers. The main goal was to get a 1 to 3 page report back to governments, typically state governments, but very often, like I said, we'd get a request from the center. I won't give you the details of the names because one of the challenges here obviously is, having outside organizations support the government is always a sensitive matter. So I try to omit the names, but it is very reassuring that there is a dialogue going on and that we do see the responsiveness on the part of the government, various units, not all of them, but various units to what we say. And the way the approach works is that if once we're asked a question, we answer the question. If we see that the other side comes back with more questions or is responsive, we continue the engagement. And that's proven to be relatively successful for us. So what are some of the examples of things we did on testing? So the first thing we did at the very beginning was helping states develop testing protocols. In fact, I would go back a little bit before then. At the very beginning, the goal was how to procure tests. And this is where the IDFC task force was critical because we had a number of folks that were working logistics, such as Bayer Vijani, who could help identify sources for tests and reagents and even PPE in other countries, including China, and then actually arrange the flights for them to come in despite the lockdown. So that was a really intense period, but that was the first step. It was actual action to get tests in. But once they were in, a lot of states found themselves with very few tests. And we had to tell them, okay, given that you have very few tests, who should you allocate the tests to? And what inferences should you make from the tests? And so there are a number of states where we did that. Other states that had a lot more tests and could actually think about doing both track and contact tracing, and could also think about community transmission. We tried to set up protocols for them to do that analysis, that sort of testing. An important issue that came up in this context is how to deal with the quality of tests. Very often the manufacturer reported quality differed from the quality that was observed in the field. Sometimes the stuff observed in the field was incorrectly tested, and so we went back to the manufacturer's results. But other times, they were imperfect tests, in which case we stressed very often that there were known statistical formulas that could very often correct for the errors, so long as the prevalence wasn't too low. And so we did a lot of that statistical advice early on as well. Another thing that we did, because we knew early on that testing was difficult. It was both difficult to get tests, difficult to get high quality tests, and it was difficult to logistically roll out tests. That was a very key issue that we had to deal with. We talked about to a number of governments how you indirectly track COVID. Can we get it from medical claims data from health insurance? What other sicknesses can we look at that might be masking COVID? And this often veered into medical protocols, whether or not you should only treat people that have certain types of symptoms or do testing before you treat them, things like that. So that became a big issue that we dealt with early on. Another thing is once the testing was done, there were a number of early reports suggesting there was no community transmission. And so we wrote actually an op-ed, but also an internal memo explaining to people that when prevalence is low, unless you do a very large number of tests, there's a reasonable chance that you're going to find zero prevalence, even though prevalence is positive and significant. And so that was a warning that we gave early on that we could underestimate the disease, especially the spread in the community, if we take too seriously the zero findings that we had early on. Finally, we've been working a lot with governments. There's a difference between the there's a lot of political pressure and practical reasons to test people that show up at hospitals or travelers, things like that, which is not necessarily representative of the population. And so one question is, if you can't do representative sampling for whatever reason, what inferences can you make from non-representative sampling? And so we've been spending a lot of time advising governments on that and writing papers. We're beginning some work on this, not beginning, but we're beginning to write up the academic version of some of these early papers or memos that we wrote. Then another important thing is that we actually did active surveillance in a number of places, some of which you may have heard of. So the first is we worked with the government of Bihar in now what is now a publicly posted paper, looking at what is the prevalence around India if we just test labor migrants. So the story here was after May 4th, there was a release from lockdown. A number of labor migrants had left cities and returned to their rural homes, ancestral homes. One of the largest recipients of this was Bihar. They got over 2 million people. And Bihar, when we were talking to them, we encouraged them to do testing, in particular random testing, and they did, of labor migrants coming in. They also tracked where they came from. And so we had a unique opportunity to see what is the prevalence throughout India based upon labor migrants that came into Bihar. And so what we found is we had underestimated prevalence, and this is active infections, by about 2%, 2 percentage points. And so that was quite significant. And we found another very notable result was that there was not a very high correlation between officially reported results and the results of our random testing of Bihar migrants, meaning the correlation between different states' official reports of testing positive rates and the actual random sampling results based upon migrants from those states, which led us to understand that selection was a big issue or non-representativeness was a big issue in the state sampling, in the state testing. Then the second is the Mumbai Serological Survey, which I'll talk about a little bit in another slide, which is a survey where we, in the first 2 weeks of July, went out to 3 wards. They're representative of the 3 major zones in Mumbai, so the city, west suburbs, east suburbs. We went out and we surveyed slum and non-slum areas in a representative sample, geographically representative sample. So that was an extensive effort. We're now beginning the second round of that this week, actually, tomorrow. And so you'll be able to see 2 time points, what has happened to prevalence. I think that the results of that really surprised people. At the same time, we had a survey ongoing. It's still ongoing. It should end in about 2 weeks in Karnataka, where we went statewide and got a representative sample. And so we are excited to report that in 2 to 3 weeks. We will be looking at both rural samples and urban samples. We did both surveillance for active infection as well as antibodies, which allows us to not only know what is going on to the number of infected and recovered, but also we'll get both recovered and future recovered, because you can add the 2 up together to get a prediction of what's going to happen in terms of the recovered population down the road. So that'll be, I think, an interesting result. And then more recently, we've begun doing work on trying to understand how long, once you have prior exposure and once you're recovered, how valuable is that immunity and how long does it last? And so we're beginning a project that's still in development to track a bunch of frontline workers over time, ones that are serologically positive and serologically negative, and see how their viral loads change over time to see if they've been exposed to infection and whether or not they actually get infected. We'll also track their antibody count and hopefully their T cell count too. So we'll be able to see when antibodies decline and if T cell immunity continues beyond that point. So I want to quickly break and just talk to you about the Mumbai Serological Study. So I think people have seen this. So this was reported out. It's a BMC press release and a TIFR study in collaboration with Niti Aayog, Kasturba Hospital, THSTI, and others. We're co-investigators, Manoj Mohan and I, on this project. And I think the thing is that this really, I believe, changed the debate in India on COVID response, because it had some notable results. And most importantly, it was that in slums, you had prevalence that was close to 57%, serological prevalence. That means 57% of the population tested positive for antibodies. assuming perfect sensitivity for the test, that means that 57% of the people have already recovered and should be in the immunity phase. If you account for imperfect sensitivity, these numbers are actually higher. There's a full report that'll be coming out hopefully within the week on that. Also notable is that the non-slums, which are in the same ward, actually have meaningfully lower seroprevalence, 15%, which I think was a surprise. There's such a big gap between these two areas. This has really changed, or I would say lit a fire under the, in the literature on modeling COVID. People are now really taking very seriously that contact rates may vary across people and across communities, and that can have meaningful impacts on both the progression of the epidemic, but also the threshold required to achieve herd immunity. It has also led to very interesting discussions about what to do with the lockdown going forward. Should we allow people from slums to be released and mix with the rest of the population? Will that actually reduce the risks in the rest of the population or not? So I think those are very important policy debates that are going on. So let me just return to this. Okay, so that's the Mumbai, that's the testing. Now I want to turn to modeling. So just as important as getting information on the disease is knowing how to interpret that for the purposes of policymaking, projections, things like that. So the very first thing we did when we started work here, we got, for the COVID group, we got a request in from the central government asking us, look, we've received a large number of studies and they all predict models, and they all predict very dramatically different results in terms of what fraction of the population be infected, what are the death rates and things like that. And so the very first thing we did is we tasked a bunch of MIT folks to analyze all different models, meaning we take all the models in, we try to replicate them, produce the exact same results. And we learned something very, very important. First is many models were not transparent about what they did. And so it was very hard to even replicate them. So they're a black box and they could not be assessed. A number of models that did reveal things, it's very important that they did. We found some errors in the coding or kind of differences between what was written and what was coded, I would say. And that was very important. The third thing we found is often these models, in a way that was not entirely obvious to readers, led to particular results because they rigged the models to get those results, and that was a little bit problematic. The fourth thing is that all the models we evaluated or were able to evaluate were very sensitive to parameters, meaning whatever, a model is a simulation. You take a model that says there are 3 types of people in the population, let's say, susceptibles, infected, and recovered. People move between those 3 categories in a particular way. These are called compartmental models. But the rate at which people move, those are regulated by parameters. Some people call them the contact rate, the recovery rate, things like that. Well, those are critical parameters and you have to estimate them. Now, if you move them a little bit, the results in the model can change dramatically. And your predictions can vary dramatically as a result. And so that the parameter sensitivity is something that a lot of the models hadn't dealt with. So that was the first thing we came back with, which is we said, we can explain why the models generate different results, and we have no reason to think that one is better than the other. The key lesson that we take away is twofold. First is use as simple a model as possible. Don't try to write a complicated model just because it's complicated, because if you don't have the data to estimate those parameters, it's garbage. The second thing is that it's critical to constantly update your estimates of the parameter based upon the information you're getting from the real world about COVID prevalence. And so this updating of reproductive rates is critical. So those are the things that we did. And when we did our own modeling, we incorporated those 2 features. That's the third item on the slide, which I'll talk about in just a second. This is our particular model of the epidemic and the use of dynamic control techniques to help guide policy in controlling it. Then the third thing we did was actually recently we've begun modeling containment zones, which is kind of control zones that are smaller than the level of a district, perhaps even a ward. They're at the level of either a building or a block or a community. And we tried to look at exactly how valuable these things are. It's a little bit complicated because containment zones have two effects. On the one hand, they stop interactions between people inside the zone and outside the zone, which can be helpful if the people inside the zone have a little outbreak. But the flip side is within the zone, it increases contact rates, so it's accelerating the epidemic. And so those people are bearing the burden of a containment zone. And one of the things that's particularly confusing beyond that is that the time at which you release people from the containment zones makes a big impact. If you release them too early, you will have accelerated the number of infected. And then if you release too early, you'll actually increase the amount of infected people that are roaming around in the general population. The flip side is that if you keep them for a long period of time, they'll become recovered, they become a positive benefit to society, and then you want to maybe release them so that they can benefit everybody else. But let me turn back to adaptive control. As I said, the main thing that we do in adaptive control is a simple model with updating the reproductive rate, constantly estimating new parameters. But the other thing that we do is we apply this idea of dynamic control. In our context, that is having gradual changes in your social distancing policies, doing that at the local level, so district level, ward level. And then the third thing is changing your social distancing gradually in response to triggers. And the triggers can be something like, what is your reproductive rate locally? It could be, what is the trajectory of the death rate? It could be your excess hospital capacity. But the key thing is to define a trigger and respond to that. And so we did that, and we showed through simulations, and we warn when we do these simulations that future projections are very surely going to be off. So what you want to do is do a lot of robustness, try a number of different simulations with different results, and compare what the performance of different policies are. And we consistently found that with adaptive control, you were going to get a lower peak and an earlier decline than you would with, for example, extending the lockdown for a little bit longer and then releasing fully later or immediately releasing, which is not really surprising results if you understand the kind of the underlying logic of these policies. Okay, let me stop there. I've gone on for quite some time. I'm sure that there are questions. So again, I want to say thank you to Aditi for hosting, and thank you to the IIC for making all of this possible.
Thank you, Anup, for that. And I think that was just fascinating. Every time I hear you talk, I get more and more, impressed with all the work that's been happening. And whenever you do know about the immunity survey, I think there'll be just a lot of people interested in knowing, because unfortunately we do have a lot of IIC and UChicago folks that have had COVID as well. We do have a question here in the question box that's, maybe it's a fairly long one. Can you read that? But just trying to understand the difference in the mortality and severity rates, and then why, we're seeing such a difference between the US and Italy versus India.
Okay, so let's talk about mortality, because this is very much at the front of my mind these days, and we're about to post another manuscript on the IFR rate in India. So a few things. First, let's talk about how IFR typically starts high and ends up a little bit lower over time. And I think one of the reasons that happens is because the very first people that we see are people that are in the hospital. Very first people that we test are people that are in the hospital that showed up with symptoms. So in a disease where there's both high symptom and low symptom people, or symptomatic and asymptomatic people, the first people we see are the symptomatic people. Those people are selected not only for being positive, but they're selected for being positive and being really seriously affected. And so if we look at death rates early on, they're really high because of that. But as we improve our surveillance, we begin to sample people with less severe symptoms. And as we do so, the mortality rate, implied mortality rate typically falls. And so we've seen that in every country. It's true in India as well. A second thing that is very interesting is that there's heterogeneity in the infection fatality rate within a country in different places. So if compare the United States, the infection fatality rate in New York is much higher than in the rest of the country, even in cities like Chicago. If you compare the United States and you compare India, India has a much lower infection fatality rate. So if you, for example, take Mumbai as an example, kind of some back of the envelope calculations that I want to be careful with because they rely on official death statistics. But if you take, so roughly 5,000 deaths in Mumbai and you divide by the fraction of the population that are implied to be positive in the past, according to the Mumbai serological study that we did, you're going to get an IFR, infection fatality rate. The benchmark we usually use is something like 0.2% because we think that's what it is for flu. Although if anybody wants to ask about that, that's not a very reliable number. But 0.2% has been this magical number. Well, we're getting numbers that are closer to 0.1, maybe slightly below 0.1%. So that's an issue, which then primes the question. And by the way, you're seeing this trajectory down also, not as low, but when we look at the trend in the infection fatality rate over time, as reported by official statistics in India, same sort of thing. You're getting a very low number, below 0.5%, Mumbai applying below 0.1%. The question is why? Why is India so low? So there are three explanations that I think we're focusing on. The first one is age. And so what we really need is we need the age profile, and we're actively using data from a number of places in India now that have finally made data available by age to look at this. And surely age explains a portion. I don't think it explains all of it. Because when we tried to do this early with official Maharashtra data, we were not able to find that age explained everything. But it is an important driver. We have a young population, and particularly slums have a young population. A second theory is that there's some cross-reactivity, which is to say people in India have been exposed to coronaviruses before, and that the immunity built up there has some imperfect but non-zero positive benefit, protective benefit as against COVID. And what that means is that you are likely to have lower symptoms, you're likely to have lower mortality rates. So that's a possibility. That's a very difficult thing to investigate. There's no studies that I know of that have investigated this, other than lab studies showing there's cross-reactivity in tests that are targeted at COVID versus not COVID. Related in this category, by the way, are these stories about prior BCG vaccine, dengue exposure, things like that. I put that all in that same bucket, so some cross-reactivity. A third possibility is that there are multiple strains of the virus circulating, and that there's high mortality strains and low mortality, or high virulence and low virulence strains. And India, fortunately, has gotten the low virulence strain. That's something worth exploring. We are actually trying, one of our collaborators, Map My Genome, and we're working with them to try to assemble a sample from private labs, a number of virus samples from around the country to see what's prevalent in each city. So that's work that's in very early stages right now. But the idea is, maybe it's the version that's low IFR. These are not the only explanations that are out there, but there are the big ones. I think one thing we should always remember is just to say thank you. I mean, just imagine if the actual IFR were meaningfully higher. And that leads me to another issue. To some extent, as bad as COVID is, it's a trial run. SARS was the trial run for Taiwan and Canada and places like that. This is India's trial run. There's a meaningful probability that there will be a COVID 2.0. I don't know what the disease will be, but hopefully we will learn this time. And we know that it's possible because Kerala had this exact same issue a few years ago when it had an epidemic, and it responded, I think, a little bit better. Nipah helped it. And hopefully we'll learn from COVID. And the thing that we want to keep in mind is the next one may have a higher IFR.
Thank you, Anup. There's another question asking, once an excellent set of simulations has been generated for the government, a lot of actions are beholden to the machinery on ground. Is there an element of adjusting for the most convenient path that overwhelmed frontline workers will presumably follow?
Okay, so that's a complicated question. So let me try this. So first, whenever you're doing planning, the key thing is, so there are a few lessons. The first one is what I call the shower principle. I have a shower, and when I turn it on, if the temperature's not right, I am always tempted. If it's too hot, I tend to turn it down. But the problem is it takes some time between when I adjust the shower and when the water changes. So I move it down and then the water's too cold, and then I move it up and the water's too hot. This lag is a big issue. The same thing happens with COVID, because the thing is, when you set policy today, it's going to have an impact on cases in 2 weeks and 4 weeks. So that's the issue. So that means if you look at what you're doing now, you're not really seeing the impact. So you might over respond and under respond in the short run. So to solve this, what you need to do is you need to project out a week or two. And I think that models can get good enough to be able to do that. And there are ways to test models to make sure they become better and better predictors. Updating estimates of RT is one way, back testing is another way. So we do these things to try to generate short-term projections. And off that, you should generate your policy. Then once you've generated your policy, the amount of social distancing required, it's important to remember, I think, that extremes are not a great thing. Full lockdown can kind of go too far in terms of restricting activity to the point where there's diminishing returns, and you have huge economic consequences, especially for the poor. Likewise, a full release is a bad idea. I think it's hard to achieve full release because people will voluntarily social distance, and you have to think about that as well. But I think that that's not the right answer. Something in the middle is right. However, and here's the big caveat, enforcement is very, very hard, right? And compliance is very, very hard. You can't have a complicated rule because your police officers are not going to be able to enforce it. It might be too complicated to convey to the community, so they can't even be compliant with it. So you have to stick to simple rules. And so when you saw all these different litany of things that could be open and closed and things like that, the first thing you're going to think is there's going to be a lot of non-compliance, because it's hard for people to know even what's allowed and what's not allowed. And the frequent corrections, that's not a good idea either, because people don't know which of the, don't see the corrections. So simple rules are going to be critical. And let me illustrate some of the issues that come up here. So we have India has low per capita police force relative to other countries in the world. It's very low. I don't know the statistic off the top of my head, but it's on the far left of the distribution for countries. Now, what does that mean? That means that police can be quite effective at a lockdown, a very, very severe lockdown. Why? Because it's very easy to find people who are non-compliant. If the streets are supposed to be empty, whoever is there, the very few people are all non-compliant. And so a small number of police officers can enforce that sort of thing. But then once you get to an intermediate level of lockdown where you say, okay, no, now only people in certain industries are allowed on the streets, or only people of certain ages or people without comorbidities, now the problem the limited police force has is, of the thousands of people you see on the street, find the small number that are non-compliant. That's much more difficult to do when you have a small police force. And so you need to think about that. The extremes are somewhat easy. These other ones are hard. You want to think about rules that are easy to see. So for example, you can enforce mask wearing. So even if there's thousands of people on the streets, if you say you have to wear masks in public, like when you're outside of a car or when you're in a shop, that is easy to do because you can see very quickly. So you got to think about enforceability very much when you're proposing these policies. The other thing is that there's a counterintuitive element to this. The goal with slowing an epidemic is to create fewer contacts. It's not just to stop activity or to restrict where the activity occurs, restrict activities in a way that reduce the number of contacts. So the classic example I use is limiting store hours. People think limiting store hours reduces contacts, and that's not true. It often has the opposite effect. And the reason is, if demand doesn't fall, if you cut the store hours in half, but demand is not cut in half, then that means all the people are going to show up in half the hours, you're going to double the contact rate. And so that's not a very good idea. So you need to think about those restrictions, which restrictions help. In fact, counterintuitively, it might be better to have shops open 24/7. The demand doesn't grow dramatically, but that the people are spreading out their contact. It's better to, for example, have limits on the number of people that can be inside the shop, so long as you can stop massive queuing outside the shop. So these are the things that I think are counterintuitive to people, and you really have to think about when you think about this response. I hope that was all responsive. I don't know if I fully answered.
I think there was, Anu, but there's the next question is kind of related, and I guess based on the serological survey in Bombay. So I mean, if it's showing that 57% of the population has already been infected, and we didn't really see a big load coming onto the hospitals, then the kind of lockdown that India had, how do you justify that? I guess that's the question.
So it's a little bit complicated. So first I want to point out that it's a sensitive issue. Okay. I think that there's I'll be as blunt as I can be. We have to work in collaboration with the government. Shreya knows this very well. When working in collaboration with the government, one must think about constructive criticism rather than just blunt criticism. Both people are trying to help out, and the goal is to try to provide feedback in a way that is likely to induce the other side to take steps that are positive. So in that context, I want to be a little bit careful about lockdown. So in some sense, the advantage of lockdown, I mean, I think if you think about it, the burden of COVID is going to be, and the benchmark for the burden of COVID should be other first-time zoonosis events, meaning other diseases the first year they show up. So the right comparison for COVID is not, is it as bad as seasonal flu? It should look at the Hong Kong flu in 1968, which is the first time you see H3N2 come out. That's the real comparison. How many people died there? How many people died here or are likely to die here? I think if we look at from that perspective, this is a significant event. Okay, this is not your typical pandemic. It's worldwide in scope. The total number of deaths is big. It doesn't have to be 1918. It doesn't have to be historic in terms of the fraction of the world population, but it is very big. It is a once in a century type situation or once in a half century type situation. Okay, given that, the lockdown was very helpful if used constructively. So the key thing to do in a lockdown is to stop everything, gather information, prepare supplies, and act. Now, I do think that that might have been the initial goal for the government, but the difficulty is that India faces logistical issues. It doesn't have great information on hospital capacity to begin with. IIC was helping tremendously in trying to get that up and running. It doesn't have great information on surveillance. The infrastructure is not that great as it is for existing diseases, like trying to fix that very quickly. And also it has a low police force. These are all things running up against the government. And so that, plus the fact that humans are humans. There ends up being politics in a lot of this stuff, especially since there are differential costs of the lockdown in different groups of people. I think that made it so that we didn't take as much advantage of the lockdown as we could have, for reasons that we can't easily solve, to be fair. We could have done better, but it's not obvious that it would have been tremendously better. But then once we acquire that information, if we could then switch from an extreme version to something that was more graduated. And we did that to some extent in May. Perhaps it could have been done a little bit earlier. I think we were still learning. It would have been great if we had better information infrastructure to know that we could have eased in different places, like in rural areas before and after. I think that would have been something that would have been very helpful to do. And now going forward, I think, again, getting to the core of the issue is we want to ask ourselves, what happened in Mumbai? And I think the debate on lockdown is complicated. On the one hand, you could say, look, the disease would have spread more in the non-slum areas, but for the lockdown, okay? And so instead of seeing 57 and 15, maybe you would have seen something like 45 everywhere, something like that. I'm making that up. I want to be very clear, but it's unclear what the counterfactual would have been. It's worth debating. But at second time, it does make us think, is a continued lockdown helpful? For a few reasons. First is the very low-hanging fruit is if you've got a very high recovered rate in the slums, would it be helpful for them to circulate in the rest of the population so that there's actually less probability that any infected person is going to interact with a susceptible person in the non-slums? They're more likely on the margin to now interact with some recovered person. So that's a very helpful thing. But the other thing is that it also tells us that we could reduce the economic costs of the lockdown on the very poor, perhaps by releasing early. The only thing we need to remember, though, is there are other things that are going on in society, which is why this is not a complete endorsement of ending the lockdown. I do believe easing the lockdown probably makes a lot of sense. But one of the things that we want to think about is the following. There's this totally separate phenomenon going in society that we need to keep in mind. Remember the Bihar study. So in the Bihar study, what we learned was that, and everybody knew this, you could read the newspapers and you'd see, as soon as it became obvious that a lockdown was going to happen, some people left the city to go back to their rural homes. But when the lockdown happened, that stopped. And then when we released from lockdown on May 4th, there's this massive exodus. When we did our serological survey in slums, we saw lots of homes that were locked up. And we talked to community folks, NGOs in the community, and they said there are lots of homes that are locked up. Even my research projects that were going on, they were non-COVID related, but related to slums, there was a ton of door locks, which tells me a lot of people left. And so what we were worried about initially was that there's this massive de-urbanization that was going on, especially amongst the poor, which is problematic from a long-term perspective. But then we were surprised. People that went back to rural areas realized, yeah, there was no work in the cities, but there's also no work in the rural areas. And so that wasn't very good. And I think their beliefs on maybe COVID had changed. At first they were fleeing COVID and now it's not clear, but we saw this meaningful reverse migration going. So we call this a reverse migration. And we suggested, I think in an op-ed, that you could actually end up with kind of fueling the epidemic again in cities. So that's the real issue, is that if we release from lockdown now and we have this massive reverse migration that's continuing, that is to say reverse coming from rural areas of susceptibles to urban areas, you could feed the infection without a lockdown. So that's the only thing I'd want to keep in mind, and I'd want to model those two things out. But strict lockdown, I think, is a harder argument to maintain now, given how high level of immunity you have. Sorry for the long answer, but hopefully that revealed a few things.
No, Anup, I think that's fine, because there's one of the debates that's been happening, frequently at the booth group. So it was great to clarify that. Anup, Navika also wants to know how you think different individual states in India are doing.
Okay. Before I answer that question, I want to point out something. I am being purposefully vague. It's not that we can't get an answer and we can't simulate possible alternatives. It's that we want to be careful about the criticism at this point so that we can continue having engagement, okay? And I think that that's a healthy way to proceed. But I can reveal some of kind of the analytic insights. Now, how are the different states doing? Look, there's a lot of variation. We knew that beforehand. You take any particular outcome, there's variation in India in terms of what is your, in the health context, what is your healthcare capacity? What is the health of the population? What is the financial situation of the state and being able to provide for financial support for health conditions? And, like the classic division is between South states and North states, but it's actually somewhat more complicated. There's some well-performing states. Take a state like Gujarat. It's going to perform differently than say, pick another state like Jharkhand or something like that. We saw a little bit of that being replicated here. So that's an important source of variation. I would say the states that have kind of been remarkable, first is I would put Kerala on the list. Their experience with Nipah had led them to become very, very proactive. And I know that they don't always get along with the center, but they did do a lot of things that I think we could learn from. And my hope is that India for COVID 2.0 will be a lot more like Kerala. That would be great. But I also want to highlight, Mumbai and Maharashtra are a little bit complicated, right? It's like the debate in New York. Did they do a good job or a really bad job? And in some sense, I want to say if they had such a high density and such a high burden, you do want to pause and say maybe they didn't do such a terrible job. I think the area where we could have seen a lot more work is trying to build up healthcare capacity, which is tough to do. But I think that for a country, for a city as rich as Mumbai should have been possible. The one thing I will tell you is that, politics really makes it hard for people to respond. I don't like the politics. If I could just get away with the politics, put away the politics, that would have been great. But I do get the sense that politics really undermine the response. It caused people to pay attention to political outcomes rather than just COVID outcomes. So I would put Maharashtra somewhere in the medium grade. I think some states that I worry didn't take COVID as seriously. Telangana comes to mind. Hasn't actually experienced necessarily a huge hit, and that might be because they were fortuitous. But the testing rates were particularly low, and that was an issue. Some states that I don't really blame so much because they don't have the capacity and they weren't able to get the tests for being a little bit behind the curve, or places like Assam. Just not getting access to tests makes a huge deal. So you can't really ramp up your testing efforts. So that's the second issue. A third issue is just, if you're a rural state, you did better than if you're an urban state. Any urban state was hit harder. And that had nothing to do with you. It had the fact that you were dense. And so that's going to be a big driver of what you see. And that has to be filtered out. Okay, so let me stop there. I think that's what I would put the state responses at.
So Anup, before I go to any other questions, there's a question from me. I've always wondered. So we saw Europe hit badly, a couple of months ago before we even came to India. But then they kind of leveled down, right? And then they stopped, and there's barely any cases in, like, say, Italy today. Versus, our trajectory seems to keep going up. US kind of kept going up. So what did Italy, Spain, etc., do that kind of just stopped having more cases?
First, comparing Italy and US is a bad idea. And the reason is because the US is a huge population that's all of Europe, basically. Okay? So if you want to compare Italy, pick a state to compare it to. Italy versus New York State. So that's a very important thing, is that you can't, these nation state boundaries for measuring COVID is a terrible idea. You should look at populations. If your average population, you want to say 40 million people, whatever number is 25 million people, you should look at units that big. So I don't think that's a healthy way to compare it. And the way to see this is that epidemics are very local. You can see that in Mumbai, right? The epidemic played out differently in slums and in non-slums in the same ward, okay? So surely it can play out differently in Maharashtra and Tamil Nadu, picking two states. So you should think about it that way. So when it's the sum of local epidemics, that really helps you understand what those disease curves are. So if I took the disease curve for all of Europe, it would look like it goes up and then stays flat for a long period of time and then comes down. And the reason is because it's a series of epidemic peaks that are happening in different places at different times. So it goes up and down in one place, then up and down another place, up and down another place. But the outer envelope looks like a flatter line. That's what the United States data are, right? It's different states getting this at different times. Florida got it much later than New York. And so that's the way I think one ought to think about it. That's also how one ought to think about it in India. The aggregated results, it's of 1.4 billion people. That's like if you took the United States, Europe, and like Africa and put them all together and said, let's look at COVID and how it's working. That's not very constructive. So that's one thing to keep in mind. Okay. A second thing to keep in mind is there are what we care about is social distancing. Social distancing is effective. So what we want to look at is not just official rules on social distancing, but private rules on social distancing. Sweden is the classic example here. There's going to be some places where the government's very, very strict. And then if they weren't strict, the people wouldn't have done anything. They would go out and go to parties and things like that. But in other places where even if the government weren't strict, people would have done that privately. So we want to look at those two different inputs into social distancing. So what I really think is more important is look at the level of the epidemic in a particular place, look at the amount of social distancing or precaution that you see, and then there are two potential inputs into this: official laws and private behavior. Okay, and that's the construct that I use to understand, and they're substitutes for each other. So you don't always need hard rules to understand this. A third thing that's, I think, very important is to understand that controls and timing of controls really have an impact. So for example, if you have, let's suppose that only rules matter, people's private behavior, as soon as you release the rules, they do everything. In that context, when the epidemic is going up and then you put a temporary lockdown in it, you'll stop it. It'll slow down, it'll begin to come down. But then if you release this, it'll just resume its normal path, and so you'll see a second peak, okay? So that's something that we have to keep in mind, that that's possible. And the thing that I think beyond that that's important is that international travel is gonna be a critical portion of this. So if you're New Zealand and you've really controlled this, but then you open up to trade or you open up to international tourism and, Indonesia, I don't want to pick on Indonesia. Let's pick on another country, some other country like India hasn't controlled it as much, and some tourist comes from India, you can reseed the infection. So in some sense, this is a global phenomenon where national controls, as soon as if you release the travel bans, you could have a reignition of the disease. So in some sense, the least common denominator country is going to drive the global outcomes. The last thing I'll say is we're still learning about the immunology. My prior is that there's a big immune benefit from COVID, not because I have great direct data on COVID, but because I look at the range of other diseases for which prior exposure matters. And I look at what we know about the rate of mutation. This isn't like seasonal flu as far as we know. There's some mutation, but maybe not as dramatic. So my prior belief is that you're going to get a lot of immunological protection from prior exposure, and hopefully then also the vaccine. But the thing is, we don't know. And so it's important to do these studies to understand what is the antibody profile, what the T cell profile, what is the reinfection risk, so we can get a sense of how secure we are going forward. Actually, the most important thing we'll learn is what is the herd immunity threshold. And then after that, we'll learn how long it'll last. And then when we get to vaccines, we'll learn Do we have to have booster shots? Do we just do it once? Or does every year, 2 years, we have to get a booster shot in vaccines? I think those are things to keep in mind. That's going to affect how we interpret Europe, I believe.
Thank you, Anup. I think we're at time, but that was absolutely fantastic, and I'm sure everybody really enjoyed it. I think we have a few more questions, and we'll try to see if you can maybe answer them over email, and we can get them back to the people who asked them. But thank you so much for this, and whenever you do have the next set of your survey findings, please do share so we can share it back with everyone.
We'd be happy to. Thank you very much for having me. I appreciate it.
Thank you.
Okay. Bye.